Okay, then you can start the class. Okay, whoever is see, I cannot hear anything.
Ma'am, is my screen visible?
Yeah, it's visible now.
Ma'am,
Okay.
a 29-year female patient named Lakshmi of Madhurwada, who is a housewife of blood group B negative, and and her last menstrual period was 11 September 2020, and her expected date of delivery is 18 May 2021.
Okay.
Her husband is of 31-year-old, who is a farmer, and his blood group is B positive. They are of low socioeconomic status. She has come with 9 weeks of amenorrhea for her first antenatal visit. History of present pregnancy, which is spontaneous in conception.
Hey, you didn't tell me her obstetric formula.
Ma'am, after this will be, ma'am.
You have to first tell the obstetric formula.
Ma'am, it will be in obstetric history, I wrote, ma'am.
No. You have to tell before, even before the chief complaint. As soon as you tell the EDD, you have to tell her obstetric formula.
Oh,
Because how will I know what type of case are you presenting, whether she is a primary or second gravida? How will I know?
yes, ma'am.
You have to tell her obstetric formula, and you have to say that she has come for routine antenatal checkup. And
Yes,
then
ma'am.
chief presenting complaints are.
Ma'am, her obstetric formula is Gravida 3, Para 1, Live 1, and Abortion 1.
Okay. So, what is the importance of socioeconomic status in Rh negative pregnancy?
Ma'am, any infection?
Any infection? Infection, okay, it will affect the overall pregnancy. Otherwise, what information will you get? What information will you get from her age?
Ma'am, age is before, precocious pregnancy.
Anyone? Anybody can answer. What information do you get? Do we get from her age? If she is more than 25 or 30 years, you can assume that this is not her first pregnancy. You can simply say that it can be her second or third pregnancy. One thing is that. And another
Yes.
thing is you have to know whether she is an elderly pregnant woman or a teenage pregnancy. Even those can end because elderly pregnant and teenage pregnancies have some other complications attached to them. You have to treat not only Rh negative but also those complications also you have to keep in mind while when she comes for antenatal visits. So if you are talking about Rh negative, she can have other complaints also apart from her Rh negative, apart from this pregnancy, she can have even other complaints. Even you have to keep in mind even those things. Okay, now continue.
Okay. She is in first trimester, diagnosed by urine pregnancy test and confirmed by ultrasound. Routine ANC investigation has been advised and reports are awaited. No history of hyperemesis, no history of fever, no history of PV bleedings and discharge, no history of pain abdomens, no history of burning micturition, and there is no increase of frequency of micturition. No easy fatigability is there.
See, in all the complaints you have told me, what are the main important things which are related to your case? That means if RH negative, she is an RH negative pregnant woman. You have told me so many complaints. What are that which are particularly important in an RH negative pregnancy? What is the history you have to particularly ask this woman in case you are dealing with RH negative pregnancy?
Ma'am.
Okay, previous history of blood transfusion.
Yes, ma'am. Any drug or radiation, ma'am?
So drugs and radiation are they are like you will be asking routinely. I'm asking especially in RH negative pregnancy what you want to ask. Any other thing you want to know? Or what are the complaints which are specifically applied to your case? In all the complaints which you have told me, what is it that is very important which you have to ask the woman?
Ma'am, pedal edema.
Pedal edema, not okay. You can ask for pedal edema, but it is more important in case of PIH case. But you can ask here also. Otherwise, why do you want to ask about PV bleeding? What is the importance of PV bleeding in this case? Anyone?
Ma'am, incompetent cervix.
What?
Ma'am, incompetent cervix.
Incompetent cervix. How is it related to your RH negative pregnancy? And how will she say whether she has an incompetent cervix? The woman doesn't know that it is an examination finding. I'm asking you what are all the symptoms which will tell you or give you a clue regarding RH negative.
Ma'am, morning sickness.
Morning sickness is also it is a routine antenatal complaint. During first trimester, what are the things you will ask for? Specifically in this case,
Don't know, ma'am.
you will ask her any history of
Blood
in
transfusion.
the past. Yeah, you can ask for any bleeding per vaginum. What is the importance of that? Okay, I'll tell you later. You have to ask for PV bleeding, any history of blood transfusion. Okay.
Yes, ma'am.
And next is pain abdomen is also important. Why? Because you will know whether it is going to be a threatened abortion or a spontaneous abortion. Both of them they carry importance in RH negative pregnancy, either threatened or spontaneous, which I will explain to you when I'm once the case is over. Okay.
Yes.
Next. Okay. You didn't
Obstetric.
mention any previous history of blood transfusion. You have to
Mm,
add even that.
yes. Obstetric history. She is married since 5 years. And is non-consanguineous marriage. She is multigravida of obstetric formula gravida 3, para 1, live 1, and abortion 1. Currently, she is in 9 weeks and 3 days of gestation.
Okay.
Gravida 1. She conceived at the age of 25 years, had full-term normal vaginal delivery, which was a baby boy. At birth, baby boy was weight of 2.8 kgs and healthy and well immunized. Gravida 2 at age of, she conceived
Okay,
at the
just
age.
hold. Is that history which you have taken for first pregnancy enough in this case?
Ma'am, she delivered at village, ma'am, so no anti given, ma'am, for her.
Okay, anti was not given. Any other
Given
thing
as
you
well.
want to mention?
Ma'am,
In the first
babe.
pregnancy, is there anything she left out and anything anybody want to add to this history? Because RH negative pregnancy, in RH negative, first pregnancy is very, very important because it is supposed to be primary sensitizing pregnancy. So what else you want to ask? Okay, you have to ask in each trimester. In each trimester, what do you want to find out? Whether she had any bleeding in the first trimester, during the second trimester, any abruption, any bleeding, even in the second trimester, any history of blood transfusions, and whether, what else? In the third trimester, you said it is a normal vaginal delivery and it is
Ma'am,
a full
any
term one.
fetal hemorrhages.
Yes. After that, did she have any bleeding? How was her bleeding in the? I mean, at the time of delivery, did she bled more, or how was her bleeding? Whether she had any postpartum hemorrhage, whether any blood transfusion was required, and after that, did the baby have normal? I mean, you have to ask even about the jaundice in baby in the neonatal period, whether the baby had jaundice, whether it was prolonged, and whether any other treatment was required for treating the jaundice. And what about the anti-D? You told me she is in village, so she couldn't take any anti-D.
Yes.
Okay.
Yes.
So all this you have to find out. Each
Okay.
trimester you have to tell. First trimester, no bleeding or no pervaginal bleeding. Or second trimester, any history of hemorrhage, blood transfusion. You have to talk about all these things in RH negative pregnancy case. Okay, no. Second
Um,
pregnancy.
Gravida too at age she conceived at the age of 27 years and had spontaneous abortion at third month and spontaneous conceptus delivery managed in village, no anti-D given, ma'am.
No anti-D is given even at this time.
Yes, ma'am.
This history is very, very important. Even in the first pregnancy, she didn't receive any anti-D. Even in this pregnancy also, she didn't receive any anti-D.
Yes, ma'am.
Okay.
Menstrual history, her age of menarche was 13 years. Her past cycle was regular, which is of 28 to 30 days of cycle, and have 4 to 5 days of bleeding. There is no clots or no pain during cycle.
Okay. Even in second pregnancy, you have to tell even after abortion for how many days did she bleed? Whether it
Yes.
was for 10 days. And what is the gap between the two pregnancies, between the first and the second one?
Ma'am, 2 years, ma'am. That was in 25 years. This is 27.
Yeah, you have. Okay. And after how many years did she use any contraceptive after this abortion?
No, ma'am, I don't know.
You have to ask about even about contraceptive history. It is also important.
Okay.
In all cases, irrespective of whatever case you are dealing with, you need to ask about contraceptive history. Even in after first pregnancy, also you didn't mention any contraceptive history. You have to ask about that also.
Okay.
Next.
Her, her menstrual history, age of menarche was 13 years. Her past cycle was regular of 28 to 30 days of cycle.
Okay.
4 to 5 days of bleeding. No clots or no pain during cycle.
Okay.
Past history, no history of major medical problems, no surgical history, no history of blood transfusion, no history of any drug allergies. Family history, no history of any medical problems in family. There is no twinning in family or any congenital malformation in family.
Why do you want to ask about training in family in RH negative? Excuse me. Is there any significance of that? Okay, continue.
Personal history, she takes mixed diet. There is no loss of appetite, no sleep disturbance, normal bowel and bladder habit. She is not alcoholic or smoker or any substance abuse.
Okay.
That's it.
Then next who is going to continue?
Ma'am, 007, ma'am.
Okay. Then ask her to share the screen. Hello. Hello, everyone. Okay, continue with your case.
Ma'am, audible, ma'am.
Yeah, it is audible.
Ma'am, I'll continue the case, ma'am.
Yeah.
Coming to general examination, she is conscious, cooperative, and well-oriented to time, place, and the person. She is
Okay.
moderately built and nourished. And anthropometric measurements, height is 155 centimeters and weight 58 kgs, the pre-pregnancy weight. BMI is 24.14 kg per meter square.
Mm.
And she is mild pallor is present, no icterus, clubbing, cyanosis, lymphadenopathy, and pedal edema.
Okay.
Gait and spine appear to be normal, no dilated veins over the neck. Thyroid appears to be normal. Breast is normal, no retracted or cracked nipples, and no palpable lump.
Okay.
Coming to the vitals, pulse rate 82 beats per minute in the right radial artery, which is regular in rhythm, normovolumic, normal in character, no vessel wall thickening, equal on both the sides, and there is no radio radial and radiofemoral delay, and all the peripheral pulses were palpable.
Okay.
Respiratory rate, which is thoracoabdominal type, 16 breaths per minute. Blood pressure is 120 by 74 mm of Hg, seen in right arm sitting position. Temperature is afebrile and JVP not raised. Coming to systemic examination, CVS S1 and S2 are heard and no murmurs, no parasternal heave and thrills palpated. Respiratory system bilaterally equal air entry, vascular breath sounds are heard in all areas of lung, no adventitious sounds heard. Coming to CNS, there are no focal neurological deficits. Abdomen, stria albicans seen and bowel sounds present. Coming to obstetric examination, inspection, abdomen shape is scaphoid, umbilicus inverted, hernial orifice is normal, flanks do not appear to be full, stria gravidarum and linea nigra
See,
present.
she is 9 weeks of pregnant. She is only 9 weeks, right?
Yes, ma'am.
So why do you want to talk about flanks now? You don't have to mention flanks do not appear to be full.
Okay, ma'am. Okay, ma'am. No scars over the abdomen and palpation. There is no local rise of temperature and no tenderness. And fundus of the uterus is not palpable.
Okay, in inspection, you haven't mentioned whether all quadrants are moving equally with respiration or not. You have to mention that also.
Okay, ma'am.
On inspection, all quadrants of abdomen are moving equally with respiration.
Yes, ma'am. And investigations, urine, albumin absent and sugar absent. Coming to blood, important investigation in this, hemoglobin is 11.8 gram percentage. Grouping is B negative, VDRL non-reactive and HIV negative. HBsAg non-reactive and RBS 126 mg per DL. Rubella nil. So provisional diagnosis is a 29 years old multigravida with obstetric formula gravida 3 para 1 live 1 and abortion 1 at 9 weeks 3 days of gestation with blood group B negative, married to B positive husband with history of first term abortion, presented for routine antenatal care checkup with normal examination findings and highly suggestive of RH incompatibility risk in present pregnancy.
Okay. Okay. Now you tell me what is RH isoimmunization and what is the importance of that?
Yes, ma'am.
Okay, regarding your case only, what are the investigations you want to do for this case?
Ma'am, first blood grouping is important, ma'am, for both husband and wife.
Okay. Husband and wife blood grouping is important. Why do you want to know about the husband's blood group? The first and foremost thing you want to do is, as soon as she presents to your antenatal clinic, you want to do blood group.
Yes, ma'am.
Once you have found that she is negative, you will order for a father's blood group also, right?
Yes, ma'am.
And if the husband is positive, next step, what do you want to do?
So, like, so there is chances for RH incompatibility, ma'am.
Okay. RH incompatibility, chances are increased. So, what do you want to do? Next, what do you want to order for? You found out father is positive.
Yes, ma'am.
So,
Fetal.
any other person Anyone can answer. Once father is found out to be RH positive, what do you want to do in the next step?
Ma'am, indirect Coombs test can be done, ma'am. On mother.
Indirect Coombs test on mother you will do, but before that you want to do something else? Do you want to find out any other thing? See, if it husband is RH, if it husband is also B negative, there is no need for further testing because both are RH negative. But once husband is positive, you want to go for genetic testing
Okay,
of
ma'am.
the father's blood group. Why do you want to go for genetic testing? Because you want to know whether that RH, whatever is there, it is either homozygous or heterozygous. And Mendelian type of inheritance. Why do you want to know whether RH is homozygous or heterozygous?
Ma'am, so that chances are there for fetal, ma'am, to have a RH negative blood group also.
Yes, I'm asking you what is the Mendelian inheritance in RH negative blood grouping? Mendelian type of inheritance. Does that apply to this? Do you
Yes.
remember Mendelian inheritance? What is actually RH immunization? It is either the presence or absence of D antigen,
Yes, ma'am.
right?
Yes,
So if
ma'am.
the D antigen, whether it is present or absent, it will decide whether it is positive or negative. So how is it inherited? If father is homozygous or father is heterozygous, how does it matter?
Ma'am, if father is homozygous, so fetal blood group will be also RH positive. If he's heterozygous, there are chances for RH negative fetal blood group also, ma'am.
Okay, so what is the chance of if the how in case of homozygous parent, in case of heterozygous, what is the chance of inheritance?
I
If
mean,
the father is
50%, 50% chances are there in homozygous. In heterozygous, 75% chances for RH positive.
homozygous. See, if father is homozygous, it means both the genes are dominant, right?
Yes, ma'am.
And both the genes in the mother are recessive.
Yes, ma'am.
So when recessive and a dominant gene combines, what will happen? You will get a heterozygous thing. All four offsprings, whatever you want to have, will be heterozygous with a
Yes, ma'am.
dominant D antigen. So all the babies who are born to the parents will be 100% RH positive, right? In
Like a
homozygous.
3:1 ratio, ma'am.
How will you get 3:1 ratio? You will get 100% RH positive. There is no board here. Otherwise, I can just write and show you. If it there, RH positive, if it is homozygous, since they are dominant, all will be I'll just see. So everyone will be 100%, all the offsprings will be 100% positive. In case if the RH is it is a heterozygous inheritance, then 50% of the offsprings will be positive and 50% there is a chance of fetus being negative. So what do you do if it is a heterozygous parent? You don't have to worry at all. If it is heterozygous, no further testing is required. If it is homozygous, then you have to go for indirect Coombs test or testing for the titers. Okay, 007, are you there?
Yes, ma'am.
Sorry, I don't know your name. What's your name?
Anjali, ma'am.
Okay, Anjali. Okay, you understood that?
Yes, ma'am.
Otherwise, you take out your textbook, there is a Mendelian inheritance. In that, you can see how it is inherited. You can go through that. So if
Okay.
it is father is homozygous, 100% fetuses are positive, and in case of heterozygous, only 50% are positive.
Yes, ma'am.
So if it is heterozygous pregnancy, then you don't have to worry about much, and you can just order for an indirect Coombs test. But if the father is heterozygous, not only indirect Coombs test, you also order for titration,
Yes, ma'am.
titer test, antibody titers. You have to get antibody titer test done, because there is 100% chance of the pregnancy being affected because of RH incompatibility, right?
Yes, ma'am.
So you have got that. You have done an indirect Coombs test. Your father is homozygous. You have done an indirect Coombs test
On
where,
mother.
yeah, you have done an indirect Coombs test in the mother now.
Yes,
And
ma'am.
indirect Coombs test, your report came as positive. You have done a titer test. Okay.
Yes,
You
ma'am.
wanted to know the titers. So what is the critical critical range of the titers? When do you say it is positive? When do you say it is negative?
From 1 is to 16, ma'am.
Okay,
Till
1 is to 16 is the,
critical titer.
there will be always a range, right? You cannot say a single value of 1 is to 16.
Ma'am, from 1 is to 16 to 1 is to 64 critical titer, ma'am.
1 is to 16, no. It is 1 is to 8 to 1 is to
1
32.
is to 32, ma'am. 1 is to 16 to.
1 is to 32. 1 is
Yes.
to 8 to 1 is to 32. Once
Yes.
the titer range crosses 1 is to 4, you should start worrying.
Yes, ma'am.
So what is indirect Coombs test and how do you do that? What is indirect Coombs test? How do you do that? Anyone have any idea about how you will do an indirect Coombs test? You will take the maternal blood plasma, add to it Rh positive erythrocytes. So you will add Rh positive erythrocytes and you will incubate it. And after that, you will add Coombs serum, which is also called as anti-human globulin to that. Once you add, there will be agglutination of the blood, right?
Yes, ma'am.
Okay, once, did you understand what I'm saying?
Yes, ma'am.
You will take maternal plasma, add to it Rh positive erythrocytes, and then you incubate that. After that, you will add Coombs serum to that. Coombs serum is anti-human globulin antibody.
Yes, ma'am.
So you will add that. Once you add that, there will be agglutination, which will indicate since you are adding Rh positive erythrocytes, there will be formation of IgG antibodies in the mother's blood. Since the IgG antibodies are very, very small, they cannot bridge the gap between two red cells. So what does this Coombs serum do? It will bridge the gap between the cells and help in agglutination. So once there is agglutination, you will understand that there is IgG antibodies are present in the mother's red blood cell. If they are absent, blood will not agglutinate. So this is how indirect Coombs test is done. And once that is done, you will do antibody titer test. How do you do an antibody titer test? And what is an antibody titer? What do you mean by titer test? Antibody titer test is where there is a positive agglutination reaction in the undiluted blood. It will indicate At what level of dilution there is a positive agglutination reaction in the blood. If it is an undiluted blood, if you get, then it is still okay if 1:4 dilution. But if the dilution is very less and you get a positive, the dilution is more and still you get a positive reaction, then it is a time when you should start worrying, because it indicates that there are many antibodies in the mother's blood. So the critical titer value is 1:8 to 1:32. After 1:4, you should start worrying and order for other tests. You have done an antibody titer test. Now the result is 1:16. Now next, what do you want to do? She is only 9 weeks of pregnant. And why is she prone for RH incompatibility more than other patients, other mothers?
Because two times she did not get anti-D.
Yes, 2 times she didn't receive any anti-D. So she is already sensitized. What is sensitization? And how does RH sensitization will occur? What do you mean by sensitization? There are 2 terms. See, in ABO blood group incompatibility, what happens? There is no sensitization. Immediate reaction will occur. But in case of RH, it is a slow reaction. First there is sensitization and later on there is immunization, alloimmunization. So what is sensitization and what is alloimmunization? How does that occur?
Ma'am, sensitization means the immune system gets stimulated and starts producing the antibodies, ma'am.
And how does that occur? How does that happen?
Antigen antibody reaction, ma'am.
Yes, first what happens? And when does, because in all pregnancies, in 75% of the pregnancies, there are fetal bloods which are circulating in the maternal blood group. In the maternal blood, in 75% of pregnancies, there is fetal cells which are circulating in the maternal blood. So what do the fetal cells do? If the mother is RH negative, she doesn't have any D antigen. But the fetal cells they carry the D antigen. So they will induce an immunization reaction in the mother, and the mother will start producing antibodies against the non-self RhD antigen. So there is antibody production, and these antibodies which are produced first are what type of antibodies? They are IgM type of antibodies. IgM type of antibodies are, they are of high molecular weight and they cannot cross the placenta, because of which they are unable to do any damage to the fetus. So this is called primary sensitizing pregnancy. This happens during the first pregnancy. That is the reason why the first baby is not affected. But what happens? This will now cause an amnestic response in the mother. What do you mean by an amnestic response? Means when the mother becomes pregnant again, in case she doesn't receive anti-D and she becomes pregnant again, once she is again exposed to this fetal cells circulating in her blood, in her body, then since IgM antibodies are previously produced in the first pregnancy, the body will recall and now starts producing again antibodies against D antigen. Now the type of antibodies produced this time are, they are IgG antibodies, right? In the first time IgM are produced, now IgG antibodies are produced, and these are of low molecular weight and they can easily cross the placenta, and they will do maximum damage to the fetus if it is not checked. So that is the reason why we have to give anti-D. And how does anti-D help in prevention of alloimmunization? So first is sensitization during the first pregnancy, and during the second pregnancy, alloimmunization will occur. So how does anti-D help? Once you give an anti-D, how does that help?
And antibodies are produced.
Okay, and what happens when you give an anti-D? These are antibodies, right? They will cover the fetal red cells and cover all the antigenic sites in the fetal red cells which are circulating in the maternal blood. So there is no immune response from the mother to the fetal red cells. One thing is that, and next that, so that the fetal red cells are damaged by the liver and spleen and are thrown out before immunization will occur in the mother. And second thing is that sent to the lymphatic system and where they are destroyed. So what are the other type of antigens? Kelly, Duffy antigens are also present, but they are not as important as the D antigen. D antigen has the maximum antibody response in the mother. Now, what is isoimmunization? RH. See, we have already spoken about that. So this is how the RH. See, these are the blood cells. These are the RH negative, the blood cells which are circulating and antibodies. Now, what will happen? RH positive blood cells which are present, they will enter. Mother is having RH negative cells. Once these positive cells will enter the maternal circulation, they will generate an antibody response. And now these antibodies, IgG, which are there, they will cross the placenta, enter the fetus. Now they combine with the RH positive cells, that is antigen antibody reaction will occur, and there is destruction of the fetal RBCs, which will lead to fetal anemia. So that is what will happen. Fetus will be severely anemic in case it is not checked. So now we will proceed with our case. So you have done an antibody titer. It is 1:16, which is alarming. Next, what do we want to do? How do you want to manage the case next? Then what are all the, otherwise I'll just continue, okay? So how does RH isoimmunization occur? It will occur either because of mismatched blood transfusion or RH negative woman bearing an RH positive fetus. So what are the events in the pregnancy which will lead to RH immunization? What are all the events in the pregnancy, in any pregnancy, which will cause RH isoimmunization?
Ma'am, antepartum hemorrhage or
So you tell me semester wise, okay? In first trimester, what are the events? Second trimester, third trimester, what are the events? During delivery, in the postpartum period, so that you can remember easily and you can answer easily also. So during first trimester, what are all the events which occur which will cause immunization? Any pregnancy in the first trimester, mother can have abortions, or abortions can be either spontaneous or induced. So these abortions will also cause maternal bleed, right? Fetal-maternal hemorrhage. Some percentage of fetal cells will enter the maternal circulation. So one is abortions or induced abortions like MTPs. Others are any vesicular moles, any ectopic pregnancy happening during the first trimester, any blood transfusion occurring in the first trimester. All this will lead to immunization in the first trimester. During the second trimester, again, any preeclampsia, any blood transfusion, mismatched blood transfusion, any abruption, placenta previa, other causes of fetal-maternal hemorrhage like any abdominal trauma. These are all the events which are occurring in the second trimester. During the third trimester, during the delivery, what are all the events that can happen during the delivery which will lead to immunization? First thing is spontaneous vaginal delivery itself can lead to fetal-maternal hemorrhage. So even a normal vaginal delivery is also at risk of causing isoimmunization. Next is any cesarean sections. There is a high risk.
any post-dated pregnancies,
Yes, post-dated pregnancies. Next.
antepartum hemorrhage.
Okay, I'm talking about third trimester and delivery. During delivery, what are all the events you have to keep in mind? I am telling you, normal spontaneous labor itself has a high risk of fetal-maternal hemorrhage. Next
Cesarean,
is during delivery, any
cesarean section also.
cesarean section. Next, any traumatic delivery, either via forceps or ventouse also, there is a high risk of fetal-maternal bleed. Next is any manual removal of placenta if it is required, or if you have to do any techniques like external cephalic version in case of breech presentation or any other techniques. Internal cephalic version we are not doing nowadays, but these carry a high chance. The next is postpartum hemorrhage. It also has a high risk of isoimmunization. Yes, postpartum hemorrhage. All this carry, if there is any IUD occurring or if there is any stillbirth of the baby, all this carry a very high chance of fetal-maternal hemorrhage. Now I am asking you one more question. See,
Yes,
if there is this high chance of RH isoimmunization during the pregnancy, why are not all the mothers becoming, why are not all the pregnancies being affected? Why only some percentage of pregnancies are getting affected and some are spared? Is there any other thing which is protecting the mother? I'm giving you a clue. There are some things which are protecting the mother from immunization. And what is the percentage of mothers being affected?
on postpartum prophylaxis, ma'am.
Postpartum prophylaxis is important. But I can say that even this woman hasn't received anti-D, she can have a normal pregnancy. She hasn't received anti-D in 2 previous pregnancies, but you can never say whether she will be affected during this pregnancy or not. Why is that? If she doesn't respond and if she has a normal baby, you haven't given her anti-D in her 2 previous pregnancies. How will you explain that? Because there is something called some mothers have an innate ability of not responding to the antibodies. So women, depending on her response, are classified into 3 types. One is responders, which are 60% of women are responders. Next is hyporesponders, who respond very little. They are 10 to 15%, and some are non-responders, which are around 20% of the women. They are non-responders. So in such cases, when they are non-responders, then the pregnancy may not be affected. Next is, it also depends on the amount of the volume of the blood, fetal-maternal bleed, and the strength of the stimulus also. What is the amount? The volume of the fetal-maternal bleed, the amount of blood cells which are entering the mother's blood during her previous 2 pregnancies. They also determine whether she has any sensitization or immunization in this pregnancy or not. If the bleed is very negligible, then she may not have developed any antibodies. So there is no chance of her being immunized in this pregnancy. Next is, it also depends on the strength of the stimulus. If the fetal cells are highly stimulant, only then she might develop antibodies. If the strength of stimulus is very weak, she may not develop antibodies. Next is, another factor which will determine is ABO incompatibility. If the mother has ABO incompatibility, what will happen? In an ABO incompatibility, what happens?
Maybe students react with the mothers, ma'am.
Yes. And ABO incompatibility response is very quick. So the blood cells are destroyed even before the mother can react to the RH positive antigens. Even before the mother responds to them, in case of ABO incompatibility, blood cells are removed very quickly. So if there is an associated ABO incompatibility, then there is no question of isoimmunization.
Yes, ma'am.
And now I'll tell you, what is the significance of spacing between the pregnancies in RH incompatibility? What they say is, if the duration between two pregnancies is long, then there is a high chance of more antibodies being developed in this pregnancy, and they are very avid in binding with the fetal red cells and destroying them. That is the importance of spacing. So you have to find out in your history even about the spacing. So these are all the events: ectopic, pregnancy, blighted ovum, antibody bleeding, which we have already discussed. Next is, how does the RH hemolytic disease will develop? This is during pregnancy. RH negative mother with an RH positive baby, these blood cells will enter the mother's circulation and they will cause an antibody response. And during the first pregnancy, since it is only IgM antibodies that are formed, the baby is spared. So it is called first sensitizing, primary sensitizing pregnancy. But the second one will be is an isoimmunization, where RH antibodies are already present in the bloodstream, and now when the fetal red cells, they will enter the body, mother's body, more amount of antibodies are produced, and now this type of antibodies are IgG variety, which can cross the placenta into the bloodstream, and they will destroy the fetal red cells, leading to anemia in the fetus. So this is how the pathophysiology will occur. IgM antibodies, they cannot cross the placenta, but IgG can cross the placenta. See, IgG, they are crossing the placenta, entering the fetal red cells, destroying them, leading to fetal anemia. See, this is how the events will occur. IgG antibodies cross placenta. They attach with the RH antigen of the fetal RBCs, causing antigen-antibody reaction where they are destroyed, causing anemia in the fetus. Not only that, hepatosplenomegaly, causing also jaundice, which is called as icterus gravis neonatorum, and also increase in the size of placenta. So RH antibodies, which are coated red cells, they will destroy the fetal red cells, causing fetal anemia, and this anemia will in turn lead to fetal hypoxia and will cause stimulation of increased production of erythropoietins. Now this will lead to extramedullary erythropoiesis, leading to enlargement of the liver and spleen in the fetus, causing hepatic failure, leading to hypoproteinemia, increased in the portal vein pressure in the liver. Portal hypertension will now lead to ascites. Ascites, accumulation of fluid in the extravascular spaces, in the pericardial space, and
Pleural effusion.
yeah, pleural effusion, pericardial effusion, causing again polyhydramnios, and even in placenta, placental hydrops is also seen. These all things, when they happen, then such type of a fetus is called, what do you call that fetus? Fetal hydrops. That condition is called as fetal hydrops. Fetal hydrops, icterus gravis neonatorum, these are all short answer questions for you. You have to know. So what are all the signs of fetal anemia? So how will you know? Now, coming to our case, we have left it at and titer being positive. Next, once the titers are positive, what do you want to do? Sorry, what's your name again?
Anjali, ma'am.
Okay, Anjali, now the antibody titers. And what is the other girl's name? She is there or she left?
Yes, ma'am.
Yeah, now I am saying the antibody titers are positive. 1:16 I am saying in this mother. Since she hasn't received any antibody, IgG antigen. In the previous two pregnancies, since she didn't receive any anti-D, her titers are 1:16 in this pregnancy, and she is still in first trimester pregnancy. How do you want to proceed in this pregnancy next? What do you want to do? 1:16 titer is supposed to be critical,
Yes, ma'am.
right? You want to know whether the fetus is affected or not.
Ma'am, then we go for ICT, ma'am.
What is ICT?
Coombs in the
Indirect Coombs.
See, indirect Coombs test is also done. It is positive. After indirect Coombs test is positive only, you will go for titers. Indirect Coombs test will tell you whether the fetus is affected or not. I am saying the fetus is affected. That is, mother is affected.
yes, ma'am.
Indirect Coombs test is positive. Now you want to go further. That is the
Ma'am,
reason why you have done a titer test. It is also 1:16 is the titer. Next test, what do you want to do?
amniocentesis.
Okay, good. Amniocentesis. You want to do amniocentesis. Is there any other alternative to amniocentesis? Since she is only in still 9 weeks, you want to do before amniocentesis, you actually do amniocentesis at 16 weeks. At around 9 to 10 weeks, there is something else you can do. What is that?
Cardiosynthesis, ma'am.
Chordosynthesis is no. You have to do again at 18 weeks chordosynthesis and all. At around 9 to 10 weeks, what is other thing you want to do to see whether the fetus is affected or not?
Fetal blood hemolysis can be calculated, ma'am.
How will you calculate fetal blood hemolysis?
With the fetal RBC and the maternal RBC.
How will you do that? Now, previously, what they used to do at around 9 to 10 weeks, they used to do chorionic villus biopsy.
Yes, ma'am.
Around 9 to 10 weeks, it is done. And in chorionic villus biopsy, you will see, you will calculate the reticulocyte count, serum bilirubin, the fetal blood group, everything you will get, all the details. And if you find that the fetus is affected, what will you do? Since she is 9 weeks, you want to terminate the pregnancy, go for termination, explain the parents that the fetus is affected. There is no point in continuing the pregnancy till term and you want to terminate this pregnancy. Right?
Yes, ma'am.
Otherwise, what you will do? If the antibody titers are negative, indirect Coombs test is negative, what do you want to do? You want to proceed with the pregnancy and if everything is normal, what do you want to do?
Anti-D can be administered, ma'am.
Anti-D can be administered, but before that you should start. Okay, anti-D can be administered. You will continue to do ICT. And what is the interval of ICT?
Ma'am, till 24 weeks, for 4 times.
Yeah, every 4 weekly you have to do till 24 weeks. And after 24 weeks,
Can be done, ma'am.
every second weekly, 2 weeks. Once in every 2 weeks, you have to do ICT
Yes,
to
ma'am.
see whether the pregnancy is affected or not. So once you find out that at around 16 weeks, if the pregnancy is affected, you find out that ICT is positive and titer test is also positive, 1:16. At around 16 weeks, you can go for 16 to 18 weeks. You can next do. What do you want to do once at 16 to 20 weeks? If you find out that these are positive, you want to do amniocentesis, right?
Yes, ma'am.
See, your time is already over, but is so much to discuss. We haven't even got to half of the class. So we'll continue in our next discussion, right? RH negative. Okay.
Ma'am.
We'll continue our discussion RH negative even in the next class, right? Because we completed only half and it is already 11. Anything you want to ask me? There are some other things which I need to cover. So we will discuss RH negative. We'll continue our discussion even in the next class.
Okay, ma'am.
Okay. All the best to you. Continue reading so that we can have a good discussion in our next class. Right?
Yes, ma'am.